So your Norvasc and your Cardine can cause a little bit of edema buildup. Usually, amlodipine will cause that. Verapamil will cause constipation pretty significantly, but again, you don't see that a lot anymore. A lot of people have it pretty bad. Increased risk of hypotension when taken with nitrates and or a beta blocker, which makes sense. Basically, if you're taking two vasodilators together or two things that slow the heart together, it's going to drop your blood pressure pretty significantly. Monitor for AV block when given diltiazem or verapamil because they work on the heart, so very similar to what you look at for beta blockers because you're slowing your heart rate is your primary mechanism of lowering blood pressure. Any questions so far or anything like that? We kind of go through these fairly quickly because there's a lot of stuff to go through. So if you have anything, just feel free to stop me. It's fine. ACE inhibitors, so we're working on the kidney now. Basically, if you're in krill, it's an ACE inhibitor. The way that ACE inhibitors work is that you have an angiotensin converting enzyme that converts angiotensin 1 to angiotensin 2. Angiotensin 2 is your basically really bad chemical that causes hypertension and a lot of bad effects. So decreasing the production and the conversion from angiotensin 1 to angiotensin 2 is a way to lower your blood pressure. Hypertension and heart failure. So in heart failure, it actually decreases the amount of remodeling of your heart. So it works in that regard, so it's a mortality benefit in heart failure. Hypertension, very important in diabetics because you can have a renal benefit. Hyperkalemia is a big thing, so it increases potassium basically in the bloodstream. A dry cough, so you hear people sometimes they'll take this for a couple of months and all of a sudden just have this hacking cough, they don't know where it came from. It's a buildup of byproduct caused by an ACE. So an ACE inhibitor can build up bradykinin as a waste product. Bradykinin is increased risk of angioedema and also cough. So you can switch them to an angiotensin receptor blocker, so an ARB. We'll talk about that in a minute. Angioedema, you want to avoid everything because it's basically a reaction that's going to happen with any class of this drug. You want to monitor potassium and renal function periodically. They can cause acute kidney injury, basically by messing with the blood flow to the kidney. And then educate a patient on signs and symptoms of angioedema, swelling of your neck, tongue, swelling of the throat, and to avoid these if this ever happens. So angiotensin receptor blockers, anything that ends in sartan is usually your ARBs. So going back to this right here, basically what you do here is you block the receptor. Theoretically, you think this would be a more potent effect than an ACE because you're blocking the receptor rather than blocking conversion. You're not going to block all the conversion, but you're going to block all the binding here. But you're going to avoid the bradykinin buildup. So this is so looking right here, lower incidence of cough, so basically zero incidence of cough. So if you have somebody who has a dry hacking cough with an ACE, this would be a drug you could use. Lower incidence of angioedema, but not absent. So if you have angioedema with a class of these, with an ACE or anything like that, you wouldn't want to try an ARB in its place. You would hardly ever use an ACE and an ARB together. The reason that is risk-benefit. So you can have increased hyperkalemia, increased angioedema risk, with basically not much of a lowering in blood pressure. So sometimes you'll see them every now and then in someone that has real bad protein in their urine, but I wouldn't recommend it. Usually if you see these two together, it's a mistake. It's kind of one of those things that pops up. It's like, what is this happening for? And then I have to investigate and see, are you taking both? Did you recently switch? What's going on? Direct renin inhibitors you won't see anymore. This is aliskiren. It used to be a drug that was used fairly commonly. It's really not used anymore, but just for completeness sake. Going back to this picture right here, it's called the renin-angiotensin system, right? So the RAS system. So basically a renin inhibitor means you're preventing this production of renin into angiotensin 1. So they thought, coming above here would help a lot. But it actually didn't have that much benefit. So it's very similar because it has lower risk of angioedema. It's sometimes combined with ACEs or ARBs, and there's actually combination products that are built out there with that. But you have an increased risk of hyperkalemia with a minimal benefit. So you don't really see Tacturna used anymore, but just for completeness sake. Diuretics. Big groups of diuretics depending on where they act on the nephron. Loop diuretics, I'm sure you're all familiar with as can be. thiazides as well. Potassium sparing, spironolactone probably is the most common one here. All right, depending on where you work in the kidney is how much fluid removal you have. These little percentage numbers is basically sodium reabsorption, and as you think of it, sodium, water goes with sodium. Sodium kind of controls the flow of water. We don't have any carbonic anhydrase inhibitors. We don't talk about a lot. This is mainly for like altitude sickness. So you think of like diamox, people that go up to super high elevations and get nauseous. You can actually, basically it's a buildup of bicarb, so you release bicarb and prevent reabsorption of bicarb and help with the sickness. It's not really used as a diuretic as much, sometimes in the ICU, but not very commonly. This is the proximal tubule. We don't have a diuretic that works here. If we did, and somebody can figure that out, we can make a lot of money because that would get rid of a lot of your water. But nothing really works here. This is your loop of Henle, so this is where your loop diuretics work. It's usually about 25% of your sodium. You have your distal tubule right here. This is where your thiazides work. And then you have your descending tubule here. You have your potassium-sparing diuretics, usually an aldosterone inhibitor that gets rid of your water here. So we'll talk about loop diuretics first. Their main use is edema. You don't see a lot of people on Lasix just because they have high blood pressure. It's usually, I have a buildup of fluid, I have heart failure, I have a buildup of edema in my legs, I gain weight because I have fluid on me. They put me on Lasix or put me on Bumex. It can be used for hypertension. That's usually kind of just like, oh, it helps with your blood pressure too, but the main thing we use it for is fluid. The reason we say warning in gout and glucose intolerance, it increases blood sugar, it increases uric acid in the bloodstream as well as kind of side effects. Your main things are watch your electrolytes super close, make sure you're not dehydrating the patient, and then in the hospital, if we give so much, we can actually have people that develop ringing in the ears. So that's usually used to be, in the older days, the way you knew to stop giving it to them, is when they started having ringing in the ears. And we don't see it that often now. We're pretty, we don't give them as near as much as we used to. But if you have people getting 80 to 120 of Lasix every single day or twice a day over and over because they're super resistant, and they say, my ears or I feel ringing in my ear. It can happen. It's just like probably the worst side effect they can have. But watch your potassium super close. Along with sodium and calcium, watch your magnesium. When your potassium leaves, your magnesium leaves as well. It's usually kind of two electrolytes that go together fairly significantly. And those are the two that are going to affect your arrhythmias. High or low potassium is going to cause that T-wave inversion. Low mag, if you have super low mag, you have a risk of torsades. Thiazide diuretics are mainly used for hypertension. So if you remember, before they changed the hypertension guidelines, a lot of people were on thiazide diuretics because they had mild hypertension. These can actually be used as an adjunct to loops. And the way I say that is, and anybody that's worked in, you've seen them sometimes give Lasix or Bumex plus diuryl or chlorothiazide sometimes. If you give the thiazide diuretic prior to the loop, you've blocked these areas off. And if you give the loop, you prevent reabsorption here and here as well. So sometimes if you have someone that has a real resistant edema, you'll see a doc sometimes give them, or if you see a drug called metolazone before that's given with Lasix, you see like Lasix and Zeroxolin or something like that. The reason you have that is because you block this ahead of time, and you basically prevent the 5 to 10% reabsorption here if you just use a loop by itself. If you use both and use this first, you prevent the reabsorption here when you block this as well. So you have an increased water, like increased diuresis. Same kind of things here. Watch your electrolytes. It's not going to shift them near as much. A lot of things you'll see with thiazides are hyponatremia. If we have someone that's hyponatremic, a lot of times a good thing to stop is thiazide diuretic if they're on it. That's one of your first things you'll look for. It'll drop your sodium a lot more than Lasix will. Lasix will drop your potassium a lot, and that's the big thing you'll kind of see is potassium and magnesium. Thiazides will mess with your sodium a lot more. They don't drop your potassium or magnesium near as much. Potassium-sparing diuretics, usually a couple of them are aldosterone antagonists. Some of them block the receptor specifically. Spironolactone has a role in heart failure now. About 5 or 6 years ago, they found a significant decrease in mortality with people that are on spironolactone. So sometimes you'll see people that don't need as much diuresis and their potassium is okay, and they're on spironolactone sometimes because they have heart failure as well. Big thing here is hyperkalemia. Don't take any potassium supplements with this because you're increasing potassium. As long as getting rid of water, you can have hyperkalemia. A fun fact with triamterene, which is not used that often, sometimes it's Maxide's a combination product that has triamterene in it. You can have blue urine. Everybody freaks out when people's secretions change color. This is one of those ones they can do. Gynecomastia is just common side effects for all lactone. It affects your aldosterone, it affects your hormonal system. With diuretics, administer them early in the day. You'll see them Q12 hours all the time. On a normal patient, that's not a good thing a lot of times, because if you give it to them at 2100, they're going to be up at midnight using the bathroom, and that messes their sleep cycle. Nobody's happy. Night shift nurse is not happy. The patient is not happy. So usually you'll see these given during the day. The fun fact to know is Lasix. The reason they named it Lasix is because it lasts 6 hours. So Bumex, a lot of your loop diuretics will have a 6-hour duration of action. So you can give them at 9 in the morning and 5 in the afternoon, or 5 in the evening, or 3 and 4 in the evening, or something like that. Because usually your duration of effect is about 6 hours or so. Kind of a good thing just to know in the back of your head, and this is what I remember a lot, but something you can kind of keep in your head is the basically dose equivalency of loop diuretics. Sometimes, usually it's 40 milligrams of oral Lasix, it's 20 of IV Lasix, because you have a 50% bioavailability, which is basically the same thing as a milligram of Bumex. So it kind of gives you a sense of, if I give them 80 of Lasix and they're like, that didn't work, I'm going to give them a milligram of Bumex, that's nowhere near close to what you're giving them before. So just as just a reference to kind of keep with you. Patients can build tolerance to loop diuretics over time. So you keep giving it to them, you're like, oh yeah, I gave them 40 of Lasix, it worked for a couple of years, and now it's not working anymore. They'll have to increase them over and over. So you'll see some people that get 20 of Lasix and put out like 6 liters, and you have some people that you give 120 of Lasix and they'll put out like 200 mils. So they just kind of develop tolerance. Monitor electrolytes as appropriate, especially in the hospital. If you notice any kind of arrhythmia, first thing you want to check is their potassium and their mag. So supplementary potassium is usually required with each dose. You'll see a lot of people that come from home and say, hey, I take 40 of Lasix, but I also take 20 of potassium. The reason they do that is because their loops will deplete your potassium. Potassium sparing, just be sure they're not taking, they come in with hyperkalemia, you're like, oh, I take this big potassium supplement at home too. Happens all the time. So just kind of just being aware, maybe if you're in the hospital and you see somebody on spironolactone but on 30 of potassium a day, it's like, kind of like, maybe that's not the best idea. So just electrolyte monitoring is really important in these patients, especially if they're like new additions or a few time doses, or if they come in first time with fluid overload and you're like, I'm going to give them a bunch of Lasix for 2 or 3 days and you don't check their electrolytes, you might be asking for trouble. All right, new heart failure drugs, we'll just kind of talk about it a little bit. So Entresto is fairly new, last 2 or 3 years. Seems like half the people come in has gotten a trial of it or get it from their doctor somewhere. It's sacubitril and valsartan. So it's an ARB combined with something called a neprilysin inhibitor. Neprilysin basically is a molecule that exists that vasoconstricts, helps fluid retention in the body. So basically it increases vasodilation, diuresis, and aldosterone suppression when we inhibit this, which when we've talked about is very good in heart failure. When tested against enalapril, and you'll see TV commercials about it all the time, but when this drug came out, it's really big because it decreased hospitalization against standard of care. And it actually was a fairly well-designed trial. It wasn't weighted toward the drug. It was compared to, target dose of an ACE inhibitor, and it worked better. Problem is, costs an arm and a leg now. But you'll see a lot of people that are on it. And you'll see cardiologists come by all the time and say, I'm going to switch them to a Entresto while they're in the hospital. You'll see it a lot. The big thing here is increased risk of angioedema. This neprilysin inhibitor causes risk of angioedema. If they took an ACE inhibitor before, the recommendation is to hold it for 36 hours. You can't just say, oh, they took lisinopril this morning, I'm going to give them Entresto tonight. You have a significantly increased risk of angioedema because of this neprilysin inhibition. So anytime that they come in and they switch them over, it's just important. They can't take an ACE and this at the same time. They can't just switch it as soon as they leave the hospital. It's usually a day or 2 lag time. Corlinor or ivabradine is another drug that works fairly well. It came out in the last 2 or 3 years. It works basically like a beta blocker. It decreases heart rate with no effect on contractility, which is good for heart failure because you don't want to decrease contractility in a decompensation point, but at the same time, decreasing heart rate is a good thing because you don't want it to hypertrophy. It's most commonly used when people have a beta blocker allergy or something they can't tolerate it for. It's not as It's not as world-breaking as Entresto was. Again, it costs an arm and a leg. This is not on formulary here, but you'll have some cardiologists that want to use it. You'll have some that bring it from their office and will give it to the patients before they leave the hospital. So it's just important to kind of know that's there. So antiarrhythmics is probably the most confusing. We'll talk about amiodarone ad nauseum. That's the main one we'll talk about. They differ on what class they work on. Okay, the class is different by what channel they work on. So you have Von Williams classification. We'll not talk about class 2 and 4 because we've already talked about them. Class 2 is beta blocker, class 4 calcium channel blocker. We'll talk about class 1, class 3, and class 5 is basically just, hey, we can't fit them anywhere else, so we put them in another class and made it up. Class 1 and class 3 are the main ones we'll talk about. So class 1 antiarrhythmics block the sodium channel. Okay, there's fast sodium channel blockers. It depends on what class, subclass it is, on what it does to the QT interval and what it does to QRS complex. Class 1A antiarrhythmics prolong your QT very significantly. Class 1B, which are not that common, the only one you'll really see much of it is lidocaine, will shorten your QT. And class 1C won't do anything to the QT, but will prolong your QRS a bit. But that's just kind of showing like QT prolongation is big in class 1A. Class 1A, disopyramide is a typo right here, but procainamide, disopyramide, not really common drugs you'll see a lot. Used to be more common than they used to be, or used to be more common than they are now. Main thing are side effects and QT prolongations, reason they're not favored anymore. Class 1B is lidocaine or mexilatine. Usually your code situations sometimes that amiodarone doesn't work. If you're trying to do your ACLS algorithm, you shock, give epi, shock, give amio, shock, give amio again. And then if that doesn't work, there's far down the list, it's like you can give lidocaine if you don't have amio or if it doesn't work. So you don't see lidocaine a terrible lot unless you're arrhythmia, your significant like code patients. And mexilatine is rarely used because it causes like 60% nausea. Nobody wants to take it because it makes them sick as a dog. Class 1C, you'll see flecainide a little bit. So this is more the one you'll see most often. So basically they're sodium channel blockers. You want to watch their QT prolongation is the big things for those. Kind of went over the same thing right here. Heart failure is a warning because class 1 antiarrhythmics have been tested against heart failure and they increase mortality in post-MI patients, specifically class 1A. So that's the reason they kind of fell off a bit. You usually don't see them on these drugs if they have heart failure. And living in Kentucky, we have a lot of people that have heart failure, so you don't see a lot of these drugs anymore. Main thing you'll see in hospital-wise is lidocaine. If you run a drip for a long period of time, can cause a little bit of confusion and psychosis, and if it gets super, super high, it can cause seizures. So if you have someone that's on a lidocaine drip and they're kind of talking out of their head, it could be something to do with the lidocaine. That'd be the main thing in hospital. Class 3, we'll talk about amiodarone and sotalol. Those are the ones you'll see a lot. And Tecousin, because we admit people to the hospital to initiate it. So class 3 are potassium channel blockers. They're used in atrial and ventricular arrhythmias, specifically amiodarone and sotalol used in ventricular arrhythmias. Tecousin is only for AFib. Warnings and precautions, you want to monitor for QT prolongation is specifically important for Tecousin because that's the reason they get admitted to the hospital. There's a criteria for people that are initiated on Tecousin, if you ever, that we'll bring in, and basically we'll check their EKG after every dose for the first 48 hours and make sure their QT is short because it can prolong it. As pharmacists, we actually have to go through it and look at every drug they're on and make sure they're not any kind of risk of prolongation. They have to be off amiodarone for 3 months. There's all these things you have to do with it. But with Tecousin, it's very important. It's also important with amio, but I think it's a little bit overstated as much as it is for Tecousin. That's the big one it's important for. They're pro-arrhythmic. Amiodarone can cause every toxicity in the book. It can cause corneal deposits in the eyes. It can cause hypothyroidism because it can kill your thyroid, it can kill your liver, it can hit your lungs. I mean, it basically is a very tough drug to use for a long period of time. But we use it like crazy in the hospital. Probably everybody you've ever had an arrhythmia, the first thing they'll put them on is amio. So amio, the reason we use it a lot is because it actually has class effects of all four. So it hits sodium channels, potassium channels mainly. It also has beta blockade and calcium channel blocker properties. So it's kind of like you're like, oh, it hits everything, so let's do it. And it's the oldest drug, so it's a lot of your data is with amio. Half-life's like 50 days. Long, long time. So once you finally get it loaded in the patient, once you stop it, it's not really stopped for a couple of months or so. Like you can stop it. It's not going to do anything. I mean, you're still going to have it work. Yeah, so your half-life's forever. Yeah, it is. So like when we talk about Ticasine, you'll see a lot of those things you have to stop amio for 3 months. The reason it is you need to have about 4 to 5 half-lives of the drug to clear it from the system is what we usually define it as. And your half-life's this long, it's going to take a while. Drug interactions, the interaction with statins, the interaction with antibiotics. So if they're on amiodarone, it's important to know what antibiotics they're on, because usually with Levaquin specifically, QT prolongation is a big thing. Warfarin, it can actually increase your INR by 40 to 50%. So people that are on it for a period of time, that's why we adjust their Coumadin a lot. Yeah, the biggest warning you'll see a lot of time is Zofran. Every time you give a dose of Zofran, it'll say, hey, they're on amio. You worried about this QT prolongation? And just make sure their QT's fine. This is probably one of the most overstated ones, but the biggest thing is that. So the biggest thing you'll see as a nurse is Zofran, because everybody gets nauseous and you're on amio drip. It's not a contraindication, but it's important to note. I mean, the big thing about it, Phenergan does it too. Every kind of antiemetic will prolong your QT in some point or fashion. So it's just important if you're on a drug like amio just to watch their QT when you're giving them anything else. And you'll probably have one of us bugging you about it too at some point if we're worried about it. Class 5 are just ones that don't fit in the other classes. So like digoxin, so bolus is the digoxin. Adenosine. How many of you have ever seen adenosine been used before? Probably yeah, all of you. Coolest drug I've ever seen. It's my favorite. And magnesium, usually for torsades. So we'll just talk about these two pretty quickly. Adenosine basically resets your system. You'll see them go into a flat line, and all of a sudden you'll see their heart rate kind of regenerate. Biggest thing I'll say for that, from my standpoint, is give them a little bit of sedation, tell them it's going to happen, because they're not going to be happy if you don't. And then magnesium is your antidote for torsades. It's not really, it's an antiarrhythmic in that regard. Digoxin is one of those ones that, it's an older drug. I mean, honestly, how it works is really interesting. So it increases intracellular calcium, and it acts as a positive inotrope, which is why people used it for heart failure a long time ago. It was usually a drug we used for people with heart failure, but we found there's no mortality benefit. And it actually risk is higher because of this narrow therapeutic index. What a narrow therapeutic index means is that there's a small range of levels that it works. There's a large range of levels that it can be very toxic and harmful. So you're trying to aim for like a little bitty spot here that it works, when there's a big area here that it can be very harmful. So basically, increased risk of toxicity with hypokalemia and renal insufficiency, which needs to be all patients in the hospital in general. Normal therapeutic range is 0.8 to 2. The way it works is it messes with this sodium-potassium pump here. So what happens is you have a sodium-potassium pump here, so you pump out 3 sodium for 2 potassium. When you absorb potassium here, you pump calcium out, so you have different exchangers to maintain your charge balance on cells. You'll have ion transport to everywhere, basically, is the best way to define it. But what you have here is if you keep sodium in, you also keep potassium in. Because basically, if you knock this channel out and you inhibit this, you decrease the amount of potassium you pump out, because you're trying to replace this sodium you pumped out here, if that makes sense. If you inhibit this, you're basically indirectly increasing calcium, and you increase calcium, you basically increase force of contraction. But also, it also, with this regard, decreases heart rate. Well, I'm going backwards. Oops. What am I doing? Here we go. It's used for dysrhythmia, atrial arrhythmias, and heart failure, but it's not endorsed. So basically, a lot of times you'll see digoxin in the hospital is either people that come from home that's already on it, or you'll see the cardiologist come by and say, hey, they're an AFib, I can't get them out of it, give them a 250 or 500 mic bolus of digoxin, we'll see how it works. They usually don't start digoxin because the risk outweighs the benefit. Because you have a lot of people that have renal insufficiency, people that are older, you can't check levels all the time, and they get toxic on it. So your signs of toxicity are, first of all, your heart rate really sucks. You have AV block, premature ventricular complexes, because you're basically increasing force of contraction. And if you increase force of contraction of the ventricles anytime, either with digoxin, even though it's minimal, and your main side effect of going back to dobutamine and milrinone are ventricular arrhythmias, fairly commonly. Anytime you mess with a part of the body, you can cause an arrhythmia with the heart specifically. Anytime you mess with the heart, epi and dopamine can cause AFib. Dobutamine and milrinone can cause ventricular arrhythmias very commonly. Palpitations and syncope, yellow-green halos in the vision. You'll hear this a lot. It's like, they see kind of green-yellow haze color, and they'll say, my vision's kind of changed. And nausea, vomiting is big with that. And then the treatment of toxicity is digibind. Basically what that does is what the name says. It takes all the digoxin, binds it all up, makes it inactive. Or magnesium if they're unstable because they're having premature ventricular complexes could flip into torsades. Again, with antiarrhythmics, the big things for us, EKG monitoring is paramount. Because you're messing with the heart rhythm, you want to monitor their EKG. Look at their QT. Longer your QT gets, the more you can go into ventricular arrhythmias, and that's why we worry about it. PR interval, so it's a big thing. You're already having an AV block, you're not getting anything that's going to slow the heart rate down. So beta blockades, things like that. QRS interval can prolong as well, so you're just watching your EKG a lot. Not if they're stable on at home, you don't have to check it every dose. But if you're starting an antiarrhythmic, you'll notice if you start amiodarone, you get an EKG the first 2 or 3 days. If you start Ticasine, you get one after every dose. Dose will need to be reduced in renal or hepatic failure, and then IV to PO switch as quick as possible. If you're on an amio drip, you want to get to PO as you can. All right, cholesterol drugs will go through fairly quickly. Your main goal with cholesterol drugs is to decrease your LDL. That's your bad cholesterol. Everybody wants to decrease it. Your kind of other side effects are to decrease your other issues are decrease triglycerides and increase your good cholesterol. Each works at a different site of breakdown or synthesis. So this is the best picture I could find that showed all of them. Your statins are here. Your HMG-CoA reductase inhibitors basically keeps your breakdown from here to cholesterol. Your cholesterol builds up too bad here. It gets into LDL. It gets sent out to VLDL, which is really bad. So bad, really bad. I guess V could be very bad, I don't know. Your niacin here, all of it works a different way. This prevents VLDL from being formed. Your bile acid sequestrants will keep bile acids will get bile acids out of the system, so cholesterol goes to bile acid instead of VLDL and LDL. Ezetimibe is a cholesterol synthesis inhibitor, so that prevents cholesterol from being formed. So there's a lot of different places that they work. Some of them work synergistically, some do not. The important thing is that statins are your workhorse. Everybody that has a cardiovascular problem ends up being on statin, whether they like it or not. Lipitor, Crestor, anything that ends in statin. That's why we call them that anyways. You decrease your LDL almost by half at maximal dose. You increase your HDL, and then high-intensity statins decrease triglycerides as well. So your Lipitor and Crestor higher doses are your high-intensity statins. So usually Lipitor 40 and higher and Crestor 20 and higher are your high-intensity statins. Usually people that have MIs and a lot of the cardiac patients, most of the cardiac patients are on these for a period of time. Your ADRs, muscle pain, liver issues. So sometimes for liver enzymes elevate, they'll hold it for a bit. Cataracts are very rare. Bile acid sequestrants, so equestrian, cholestyramine. It'll decrease your LDL by less amount, increase your HDL by 3 to 5%. So these from after statins are basically ones you'll use if people can't tolerate statins, or you'll see people that are on these that are have been on them for 15 to 20 years. A lot of people don't start bile acid sequestrants in patients as much unless they can't tolerate a statin. This is basically what you're going to see after these. They're like, oh, my legs hurt, I can't tolerate a statin, or oh, I have decompensated liver disease, I can't take a statin. They move to other drugs like this. So bile acid sequestrants basically excrete bile acid out, so your cholesterol converts to bile acid quicker, so you don't have that bad cholesterol that collects. Your big things are, if you have biliary obstruction and you have bile acid sequestrants, that's not a good thing because you're going to go to the gallbladder. So if you have a biliary obstruction, you don't want to use these. Drug administration timing is the biggest thing here because 1 hour before or 4 hours after is when you should give drugs after you give something like this because it can affect absorption of almost any drug. So I'll retime things like crazy if you start people on like Questran. And Questran's given Q8 hours sometimes, so you can imagine how hard that is for y'all to give meds around that. That's a big thing I don't like about these from my perspective. GI irritation, constipation, and malabsorption of fat-soluble vitamins so be sure you want vitamin supplementation in these patients. Cholesterol synthesis inhibitors, so Zetia. Zetia used to be, before last couple of years, the drug they thought worked but really didn't have any benefit, but now they found some benefit in synergy with a statin. So you'll see people on something like, I think it's Vytorin, that's like simvastatin and ezetimibe together. So you'll see a lot of people that are on combo products. Active liver disease, GI distress, I mean, it's a fairly benign drug, but it adds a little bit more to the statin. Niacin, you used to see a lot more than you do now. It decreases, its main effect is increase in HDL. It does more of that than anything else. Your big side effect of niacin is flushing. They'll get really flushed in the face. A way you can fix that is give them pre-med with an aspirin. We'll fix that usually. Fibric acid derivatives, so fenofibrate, gemfibrozil, used to be used a lot more and used to be combined with statins a lot until recently because of hepatotoxicity. It causes a lot of liver issues combined with statins, so they don't combine them anymore. Every now and then you'll have your patient come in that takes them both at home and are fine, but it's not recommended anymore. PCSK9 inhibitors are new. They're injectable. They're for people that don't take can't tolerate statins. You won't see them as much in the hospital because they're not on our formulary because they cost a lot. But you'll see a lot of people that have muscle pain to 3 or 4 more statins that'll come into the office and get a monthly injection of Repatha or Praluent. A lot of the cardiologists are moving to that because it basically decreases your HDL a significant amount.
You've had a few patients recently that's talked about those.
Mm-hmm. They're fairly newer now. The big thing is expense. If they can get it paid for, a lot of people like it because they don't have to worry about. Yeah, a lot of people don't. No,
yeah, we've had some people that's
my
been
dad,
saying that.
Skinner put it on my dad, and we can't get it.
Can't get it over here.
Yeah, it's very convenient to people that like it. I mean, because we're like, I don't have to take a pill, and I can come in once a month and get a shot. So, all right, big thing for these: give statins at bedtime. The reason that is your cholesterol synthesis is maximized between 2 and 5 a.m. It's the reason why we usually give them at night. A lot of people take them during the day, and we'll say, I take it during the day, and I'm not taking it at night. That's fine. But usually, bedtime is better effectiveness. Myopathy can be alleviated with either dose change or agent change. Your most common myopathy agent with statins is usually simvastatin, is the worst. Followed by atorvastatin, followed by usually Crestor after that. So as you go down the line, actually one of them called fluvastatin is probably the worst, but you don't see it hardly on the market anymore. It's not used hardly anymore. But usually, you can either decrease the dose, change them over to another agent, and they relieves. Some people can't tolerate them ever. Separate other medications from bile acid sequestrants about at least 1 hour before or 4 hours after. Monitor liver function, and then aspirin. Kind of covered all these as we went through them. This is kind of like your slides on here. Just be like, okay, this is the too long didn't read version, maybe. Like important things for you all to remember about these because you're not going to remember every single thing about everything. Antiplatelets and anticoagulants, we'll kind of go through these. So antiplatelets work in different areas. P2Y12s you hear a lot about. Aspirin, we all know about that more than we'd like to know. And then there's GP2B3A inhibitors that we'll talk about a little bit. Indications for antiplatelet therapy. Why do we take them? A lot of people take them for stroke. Stent placements, the big thing, a year after drug-eluting stent placement, at least a month after bare metal stent placement, ideally a year after that. Tissue valve replacement of patient have surgical valve replacements, peripheral vascular disease, or just coronary artery disease in general. People take it for their heart. So aspirin works by a COX-1 inhibitor. So basically what that does is prevents this production of thromboxane A2, which is the bad thing. Basically causes your platelet to get all spiky. And what that means is that it activates and aggregates, stick together, causes a plaque, causes a clot, causes either a issue in the cardiac area or in the neurological area. Treatment of ACS, prevention of stroke, prevention of heart attack, much more. Using caution in patients allergic to ibuprofen if they've never taken it before, but usually people can tolerate it. NSAID allergies are really interesting because they can be allergic to ibuprofen and have anaphylaxis, but can take naproxen perfectly fine. It's just a weird thing with the structures. Usually aspirin's different enough that it's okay. But it's just important to know if they've had an intolerance, just to be aware it could be a problem. P2Y12s are the more potent antiplatelets, usually used for DAPT, dual antiplatelet therapy. Probably heard that till we're blue in the face. Clopidogrel, Plavix is the most common one. Usually load them with 300, 600 prior and then put them on 75 a day after. Sometimes you'll see Plavix used on people that have strokes while they're on aspirin, or if they've had issues with clots and their, issues with their like peripheral vascular disease while on aspirin, they'll move them up to Plavix. That's kind of off-label, or just kind of how the definition of practice goes. Main thing interaction is CYP2C19 inhibitors. Clopidogrel is a prodrug. Usually your omeprazole is a big thing, so people take Prilosec at home and take Plavix. Plavix could be less efficacious. So that's just a counseling point. That's the reason we use Protonix in the hospital, because that avoids that interaction. That's the whole reason we use it. Downside is patients can be poor responders and we don't really know it. So you had people come in that say, or people get loaded on Plavix that maybe reocclude their stent, or people that come in that have reocclusion of stents. Could just be those people that have that CYP2C19 poor responder. That's just a genetic disposition we kind of find out about the hard way. So that's the reason some people are moving away from Plavix and moving to something like Effient or Prasugrel. So Prasugrel is used 10 milligrams a day, except in old people or people that are really light. You can drop it down to 5. It shows benefit in specific populations over clopidogrel, so younger patients and patients with diabetes has better results in caths, so that's why you see a lot of younger people on it. The big thing is it has high risk of bleed, and it's not. And your other problem is that it's usually contraindicated in people that's had a history of a brain bleed or a TI or a stroke, because it can increase brain bleed in people that have weaker vessels in the head. However, I say that neurologists use it like crazy. So that's kind of a recommendation in the package insert, but clinically it's not really paid attention to as much. Ticagrelor or Brilinta, the only downside on this is it's twice a day. A lot of people don't like that. But it actually does work very well with people that are younger and with same thing as Prasugrel. Your main thing here is it's contraindicated with doses of aspirin greater than 81, and not for the reason you might expect. A lot of people think it's increased risk of bleed. It's actually higher doses of aspirin that have shown to interfere with ticagrelor and not let it work as much. Everybody's like, oh, they're going to bleed. No, it's not necessarily the case. It's that ticagrelor doesn't work with aspirin 325. The trials showed that there's an increased risk of thrombosis in patients with 325 versus 81, which didn't make a lot of sense. Here's your good comparison chart. So again, just something to reference your mechanism, what your dose are, and then just something you would kind of pay attention to. So glycoprotein 2B3As are used in the hospital. The one we have here is integralin. It's usually used as a heart catheterization rescue. So basically when the interventional cardiologist goes in and sees either a high thrombus burden or just a narrow vessel, he'll add integralin onto either heparin or Angiomax while he's in there. It's not something, Dr. Skinner I know uses it a lot. I know a lot of other people use it a lot in cath lab. The main thing you'll see on this is it's not going to continue for 3 or 4 days or so. Usually if you get these patients, it's off within the same day or sooner. You'll have your off niche indication, but you won't see it much in the cath lab or CVOU. Sometimes people will run it as a bridge to CABG if they've had a recent stent put in right before they do a CABG. Just make sure that doesn't occlude while you're waiting. If you have a high-risk patient that's on DAPT that needs to be on DAPT, but you need to do a surgical procedure and you can't hold it, you can sometimes run integralin in the background until the surgery. But that's very kind of like a high risk. If they're super, super high risk, we can do that. But 99 times out of 100, it's off within 18 hours of leaving the cath lab. Other agents for completeness sake, there's a combination product called Agranox. So it's aspirin and dipyridamole. Sometimes it's used for stroke. Pleadal is not really an antiplatelet. It just makes the platelets more slippery. So you can use that sometimes with peripheral vascular disease. Zontivity is a new antiplatelet. Nobody ever uses it. I've probably never seen it here. We don't have it on formulary here. Riapro and Cangrelor are other IV antiplatelets we use around cath lab, but we don't have them on formulary here either. So pearls here, anytime you have surgery, you usually want to hold these about 5 to 7 days before. The reason that is they last with the half-life of the platelet. They don't last with the half-life of the drug. So once you inhibit these platelets with everything Brilinta, where they're irreversible inhibitors of the platelet, you have to wait for the platelet to kind of recycle. And the half-life of the platelet is about 7 days or so. So the platelets turn over about that period of time. The way you reverse it, if they're bleeding, someone's bleeding and they're on antiplatelets, give them platelet infusion. All right. All right. Anticoagulants in general work in different areas. Vitamin K antagonists, dabigatran, all that jazz. Go for it real quick. So, use them for stroke prophylaxis, AFib, DVT-PE, peripheral arterial disease, and low-dose anticoagulation can be used for DVT prophylaxis. And we'll go through these fairly quick. Unfractionated heparin, you've seen it probably more often than anything. Advantages of it is you can titrate it. Disadvantages of it is it doesn't really work. It doesn't absorb fairly as well. It's labor intensive. Everybody works different doses. Enoxaparin is more predictable. Fondaparinux is used mainly as DVT prophylaxis in situations of thrombocytopenia because it doesn't. You have heparin-induced thrombocytopenia that can exist. This kind of avoids that. Direct thrombin inhibitors, so Angiomax is the main one you'll see with this. Uses is heparin-induced thrombocytopenia, and it can be basically with issues with renal and hepatic impairment. The only time you'll see bivalirudin is either in the cath lab or someone that has HIT. Warfarin or Coumadin, oldest drug in the book that has the most data behind it, is the gold standard in my opinion. It inhibits vitamin K. So that's why vitamin K is basically your antidote. And its cofactors required to form 2, 7, 9, and 10 cofactors, and that's what it blocks. INR is what defines how thin your blood is. Your goals change based on what your indication are. Onset of action is delayed. Usually takes about 48 to 72 hours to even kick in, usually 5 to 6 days to even get therapeutic. So that's why we bridge them with either Lovenox or heparin drip. Important counseling points, drug interactions are very common, diet considerations because of vitamin K content, and signs and symptoms of bleeding. Your main drug interactions are these right here, usually antibiotics, amiodarone, and then vitamin K supplementation are the big ones. If you have a question, usually the big thing is I always tell a patient anytime if you get any kind of new drug at all, talk to a pharmacist about it, tell your doctor you're on Coumadin so they'll know. Because most antibiotics, fluconazole, Levaquin, azithromycin, will interact with it fairly significantly to the point they could be hospitalized due to drug INR increase. Basically, diet considerations, leafy greens are a risk source of vitamin K. The big thing is keep diet consistent. Don't tell them they can't ever have vitamin K in their life because they'll get mad at you. But be sure to tell them don't go from being a meat eater to a complete vegan without telling somebody about it. Because your INR will go down, they could easily have a stroke. Pradaxa, that's not used as often anymore. It's a direct thrombin inhibitor. You don't have to check blood. Everybody likes it. But the problem is, any kind of these new drugs you'll see right here with the Xarelto and Eliquis is contraindicated in mechanical heart valve replacement. Anytime it has a mechanical valve, it's going to be on Coumadin. The reason that is they did a trial with it, and people had more bleeds and more clots and more death. Nobody likes that. But basically, like, the newer drugs are used for clots and AFib, not for valve replacement. Rivaroxaban, probably see Xarelto, and Eliquis we use a lot in the hospital. The reason we use Eliquis a lot is it's actually superior to warfarin in the treatment of AFib. Decreased bleeding and less clots, is less risk of clotting as well. With apixaban, you have a decreased dose adjustment, but if they're old and small, they'll take less. The big thing right here is this will have everything in it that you need to know about these. That's good to know. Basically, key points, gold standard. You have more GI bleeds with dabigatran. Apixaban is superior in AFib treatment. Monitor for bleeding, obviously. Oral anticoagulants need to be held 2 to 5 days prior to surgery because of half-life. Reversal of bleeding is right here. The big one is protamine with heparin and enoxaparin. And this is kind of a dosing regimen. So how much heparin do you give in the last 2 hours? You give a milligram of protamine for every 100 units, or enoxaparin a milligram per milligram in the last 8 hours. Because once it's cleared the system, protamine can actually cause a hypersensitivity reaction as well. So we don't want to give like a ton of it. and cause clots or hypersensitivity reaction. But basically, they'll give you kind of a dosing regimen here. Warfarin's vitamin K. Dabigatran and rivaroxaban have their own agents that are out. But if not, we don't use those. You can use FFP. Direct thrombin inhibitors have no antidote. This is kind of a good reference to have if you ever have bleeding in this regard. Antifibrinolytics is super quick. TPA prevents or breaks down plasminogen, basically breaks down your clot. This is fibrin decay products right here. So TPA breaks up your clot. We use it for stroke. Sometimes you'll use it in STEMI if you're at a small hospital, you're in the middle of nowhere, and you can't get somebody to a cath lab. You can use it for a heart attack, and you can use it for pulmonary embolism. Doses differ based on what you've got going on. And this is basically the last thing. Contraindications to TPA. Anytime you've had a previous stroke at any origin of unknown origin at any time, so you don't know when it happened, basically, it's a contraindication. Any kind of previous surgery, any kind of bleeding in the past month, because TPAs can cause you to bleed a lot. There's like a 7% chance of cerebral hemorrhage. Basically, with TPA, you want to make sure they're not taking any kind of anticoagulants and they're not high intensity. If they have high blood pressure, just think high blood pressure plus a blood thinner can cause a bleed in the head. And this is a lot of just a list of TPA, or TPA contraindications. So high risk of bleed, any kind of vascular disease, usually if they take any kind of blood thinners, major trauma or surgery, issues like that. So the main thing is to take away is know your medications fairly well. You want to know anytime you give a medication, you want to know what you're giving it for, what could it interact with that they're getting right now, and what do I do if something goes wrong? Especially with antihypertensives, it's big, blood thinners, it's big, things like that. And then when in doubt, you got a service, we can holler at us, we'll help you out. But the main thing is, I would just say, if you don't know what your medication is, take a look at, there's links in Epic, they'll take you to Micromedics, you can read about it, just know what you're given before you give it. And that's all I've got. I know it's a lot of that stuff is like regular stuff like